All right, everyone, welcome. Today, we're going to take a much closer look at a lab value we all see literally every single day, the white blood cell count. But we're going to go way beyond just the raw numbers and really decode the rich clinical story that's hiding inside the differential. So let's get started.
Because this is really the core question, isn't it? The total count, well, that's the headline. But the differential, that's the full story. It tells us which specific immune cells are stepping up, in what proportion, and that points us toward a much more nuanced diagnosis. It's really our first big clue in a complex diagnostic puzzle. So here's our game plan. We'll kick things off with a big picture, what leukocytosis and leukopenia really mean. Then, we're going to drill down into each major cell type, our frontline infantry, the neutrophils, the highly specialized eosinophils and basophils, and then the strategists, monocytes and lymphocytes. And finally, we'll pull it all back together to see how this all leads to a coherent clinical conclusion. Okay, so let's jump right in with that very first flag you see on the lab report, an abnormal total white count. This single data point immediately starts to narrow our differential diagnosis. Now, we all know a high count or leukocytosis immediately makes us think of infection. But, and this is crucial, we have to remember the non-infectious causes. Take corticosteroids, for example. They can cause something called demargination, basically a release of neutrophils that were already just hanging out stuck to the vessel walls. This can cause a really rapid, significant spike. On the flip side, leukopenia can signal anything from a drug reaction to viral suppression or even splenic sequestration, where the spleen is just holding on to too many cells. So the total count, it's a huge clue, but it's a very broad one. And this number right here, this shows just how specific we can get, especially with iatrogenic causes. 4,000 per cubic millimeter. That's the average increase in the white blood cell count for a patient on a moderate dose of oral prednisone. I mean, this is not a minor blip. It's a significant medication-induced leukocytosis. It's just a powerful reminder to always check the med list before you jump to a diagnosis of infection. Okay, so now that we've looked at the total count, let's drill down into the differential. And we have to start with the most numerous of our white blood cells. If the immune system is an army, the neutrophils are absolutely the frontline infantry. They are the first to arrive and the first to engage the enemy. And you can see here making up anywhere from 50 to 70% of all circulating leukocytes, neutrophils are clearly the dominant players. A shift in their number, a neutrophilia or a neutropenia, is almost always the primary driver of an abnormal total white count. Their sheer numbers just tell you how important they are as the body's first line of defense, especially against bacteria. So, how do they get from the bloodstream to the battlefield? Well, they do it through a process called diapedesis. You might also know it as the leukocyte adhesion cascade. And this is not a passive thing. It's a very active, highly regulated migration that's guided by a whole symphony of chemical signals. You can really break this process down into 3 key steps. First, the neutrophil starts to slow down. It kind of rolls along the vessel wall thanks to proteins called selectins. Then, other proteins called integrants cause a firm arrest, basically locking it onto the endothelial surface. And finally, and this is amazing, it performs an incredible feat of contortion, squeezing itself between the endothelial cells to get into the infected tissue. And once it gets to the target, you better believe the neutrophil is well armed. It doesn't just swallow pathogens. It unleashes a chemical storm from its granules, using all these destructive enzymes and free radicals to just obliterate bacteria. It's a powerful attack, but it's also pretty indiscriminate, which is why chronic neutrophilic inflammation can cause a lot of collateral tissue damage. All right, next up, let's turn to the less common granulocytes. If neutrophils are our general infantry, then you can think of eosinophils and basophils as the special forces. They're called in for very specific missions. Eosinophils and basophils have very distinct roles. Eosinophils are our main defense against parasitic worms, using toxins like major basic protein. They also help control allergic reactions by releasing histamine, which breaks down histamine. Basophils, on the other hand, are the ones who start the allergic response. They release histamine and heparin, acting a lot like their tissue-based cousins, the mast cells. So an eosinophilia might point you toward a parasite, while a basophilia, that's a classic finding in chronic myelogenous leukemia, or CML. Now let's shift gears to the agranulocytes. These guys are the long-term strategists and the intelligence officers of the immune system. They're all about orchestrating a more coordinated and specific response. It is so important to think of monocytes not as the final product, but as precursors. They are essentially immature cells just in transit. Their real work only begins after they've left the circulation and differentiated into something else. And what they differentiate into are some of the most important cells in the body. In tissues, they become macrophages, the great cleanup crew, and critically, antigen-presenting cells. What does that mean? It means they gobble up debris and pathogens, and then they present little pieces of those invaders to the adaptive immune system. They're basically telling the rest of the immune system what to look for. This role is the critical link between that initial, non-specific response and the highly specific long-term one. And that brings us right to the key players of that adaptive system, the B and T lymphocytes. Think of B lymphocytes as our antibody factories. They mature into plasma cells that just crank out specific antibodies to neutralize pathogens. T lymphocytes, they're the field commanders. They orchestrate the whole cell-mediated immunity, from helper T cells that activate other immune cells to cytotoxic T cells that directly kill infected cells. They're coordinating the entire strategy. Okay, so let's tie this all together. We've gone through the roles of each cell type, from the first responders all the way to the long-term strategists. The question is, how do we apply this back to the patient who's right in front of us? And really, this is the main take-home message. A neutrophilia isn't just a high number, it's telling a story of an acute bacterial infection or a major inflammation. An eosinophilia isn't just a percentage, it's a clue pointing you toward an allergy or maybe a parasitic invader. Every single line of the differential adds a new chapter to the patient's clinical story, letting us move from a simple count to a much more confident conclusion. And that's really the question I want to leave you all with. In those really tough, diagnostically challenging cases, how could we leverage this detailed knowledge of leukocyte function to see the patterns that other people might miss? Because by looking beyond the number, we truly unlock a much, much deeper level of clinical insight. Thanks for your time.